All right. Well, let's go ahead and get started. I know we've got several people that are going to be joining us tonight, but it's 7 o'clock, so let's go ahead and get started. I will let you all know too that this webinar tonight is being recorded, so you can sit back, you can enjoy and relax. And if there are some things that you want to write down, by all means, feel free to do that. But just know that this is being recorded and that you can come back and look at it at any time. This will be posted on our website underneath our event so that you'll be able to, again, view those again at a later time. So welcome so much for being here tonight. We are talking about exploring sexuality through breast cancer. I know that there are several people that are out there that are providers, they're patients, maybe they are loved ones of somebody who has breast cancer, but just know that breast cancer affects all of us. And you probably, again, are experiencing this for yourself personally, and you're taking care of patients with this, or again, you're taking care of a loved one. And this may be something that you're thinking about now as you're going through breast cancer treatments. The other thing too could be that maybe you got diagnosed with breast cancer 10 years ago and you went through chemotherapy, or you're taking medications right now and you're still trying to think about, well, what's going on with my sexuality and what can I do about it? So this is for everybody. All right. So let's get started, right? Well, goodness, let's talk about introductions. My name is Aleece Fosnight. I am a PA. I specialize in sexual medicine. I'm in urology and women's health. I am a nationally certified menopause practitioner through the North American Menopause Society. I'm also a nationally certified sexuality counselor and educator through AASECT, which is the American Association of Sexuality Educators, Counselors, and Therapists. So how in the world did I get here? So sexual health has always been something that I have talked about. High school, talked about with my girlfriends, with people. My mom was always really, stressed the importance of knowing exactly what sexual health is. So I felt like I had the up-to-date, most accurate knowledge and knew what was going on. But it all kind of originally started of where I got started, where I'm at today, was when I was in PA school. And everybody was trying to come up with their own topics for their master's thesis, research presentations, and they were doing diabetes and blood pressure. And although I do feel that that is very important for us to know about, really wasn't something that I had a true passion about. And one day I was talking on the telephone with my mom, and a commercial for Viagra came on the television. And I thought, oh my goodness, if there is a blue pill for men, there has got to be a pink pill for women. And so I did some research, and at that time there was no medications for women's sexual health, and I was pissed off. And I thought, this is not okay. We were talking about male reproductive health and sexual health, but we weren't even talking about pleasure for women or clitorises or orgasm. And so I did my master's thesis on female sexual dysfunction in postmenopausal women, and recognized that there were still a lot of options, even though there wasn't any approved medications at that time. I also realized that a lot of those articles were coming from urology journals, and that sexual medicine actually fell under urology, but really loved the aspect of sexual health. So really made it my mission on my rotations to do a lot with sexual health. And I was very fortunate and got a job right away with a urologist back in my hometown. And this was fantastic and great, and I loved it. He wanted me to do female sexual health, female urology, and I was down. I was gonna, let's do this. I was really excited. Recognized that about a year into it, I still needed to know more. And so I found a program at the University of Michigan. They have a sexual health certificate program on a postgraduate level, went through their training, and that's how I have the sex counseling piece of it too. And we'll talk a little bit more later on in the presentation tonight about the differences between like a sex counselor and a sex therapist, and what are the things that I can do even as a sexual medicine provider to help out with those sexual health concerns. So again, in my role, again, really recognized as I was going through my clinics and my practice and my patients, and really recognizing that we had limited resources. And this was when seed was placed in my head about having a multidisciplinary center where we could talk about the biopsychosocial aspects to sexual health. And here is born the Fosnight Center for Sexual Health. We opened up in June of 2020 in the midst of a pandemic, but we are doing it. And I'm so excited to be able to really focus on sexual health concerns and reproductive health of all of my patients. Although my heart really lies on the female side of things, I love my men too, and dealing with their concerns as well. And I do see a lot with the trans and non-binary and LGBTQIA communities as well. So that is me. As fun as that is to talk, we really want to get into the meat and the juiciness of tonight's topic. So let's go ahead and get started. So let's look at the statistics, right? We kind of talked about this right at the beginning. We know somebody, we've dealt with somebody that has had breast cancer, and it is going to be diagnosed in 1 in 8 women here in the United States at some point in their lifetime. Breast cancer is the most common cancer out there for women besides skin cancer. And so this affects a lot of women. Again, it is your friend that may be diagnosed, yourself is being diagnosed, your mother, your aunt, somebody close to you that you know has been diagnosed with breast cancer. With this being said, though, there's some good news and positive news on this, is that the death rate for breast cancer is going down. We're seeing a lot more survivorship. We're seeing women living a lot longer. On the flip side, though, although we are living a lot longer, we're now dealing with the side effects that are coming from both the treatments with a surgical treatment, chemotherapy, radiation, or hormone therapy with those types of breast cancers. So it's great that we were living longer, but the quality of life sometimes is being affected. And sexual health is definitely one of those areas that we can talk about as far as the quality of life goes. Okay. So when we think about cancer, all cancers and the treatments of cancers impact sexual function and your sexuality. The difference, though, is that breast cancer, through clinical studies and research, has shown us that it is affecting the sexuality of women a lot more than any other cancers out there. So that's why we need to talk about it. Sex is super important. It is innate in who we are. It is part of our overall being. It helps us to identify our gender, our identity, our orientation, who we're attracted to, the type of pleasure that we have, the intimacy that we have with ourselves or with a partner, and our reproductive health as well. And just like I said, it has a lot to do with the quality of life that you have. I oftentimes talk to my female patients. They get super nervous, right? I should just be happy that I'm alive, that I'm beating the cancer. And that's great. And I'm super happy for that too. And we want you to have as many years possible on this earth so that you can be with your family, with your children, with your spouse, partner. But those years have to be really high quality too. And you shouldn't necessarily feel guilty for that. Everybody feels different, and you should be able to have the right to feel those feelings and feel okay and not feel guilty about that at all. Again, when we talk about cancer and the sexuality, the treatments affecting how you're functioning also, and the whole physiology piece of that too. I love this definition by the World Health Organization back in 2006. It hasn't been revised since then. So yes, it's 14 years old, but it still is very relevant. And I am going to read it word by word. So the World Health Organization tells us that sexual health is a state of physical, emotional, mental, and social well-being related to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. I love it. It's beautiful. It's all encompassing. And this is really one of the things that I wanted to look at and take on with my Center for Sexual Health. Our tagline here is to restore mind and body, empower body. I can't even remember. Restore mind, empower body, and optimize pleasure. Oftentimes, the pleasure piece is taken out of it, but it's such an essential point to your sexual health and your sexuality. Okay. So if we are going to talk about the impacts of cancer and treatments on sexual health, we have to understand the sexual response cycle. So Masters and Johnson came out in the 1960s. They had done a lot of research. They were looking at, how people respond to sexual stimuli and what is it that they go through. So after watching over 10,000 sexual encounters, yes, you heard me right, 10,000 sexual encounters, they came up with this linear model. And what it says is that you first have this desire piece, okay, down here at the bottom. Then you have arousal. So you have the swelling of the genitals, the blood flow, the breasts start to engorge. You actually have erectile tissue in your nose. So your nose actually swells. We think that is so that you have a better sense of smell. You can smell the pheromones of your partner. And then you reach kind of this plateau where arousal sits for a little bit of a time frame in order to stimulate those nerves and engorge those genitals enough that then you can reach orgasm. And then you have resolution. Although we would love to stay in an orgasmic state forever, right? We still have to get on with life and our jobs and taking care of families and things like that. So we actually have to come down from that orgasmic state in order to, again, do what we need to do. They did find in women, though, that women have the potential to actually have multiple orgasms. If they stay just above where that plateau line and don't dip down from that they're able to achieve third, fourth, fifth orgasm without having to repeat this whole cycle again. For men, that's a little bit different. They do have what's called a refractory period, which is the time frame that it takes in between each cycle. So when men are in their teenage years, that refractory period could be seconds, right? They're ready to go again. As men start to age, or there's other types of health comorbidities associated with their overall well-being, that refractory time may be now hours to days in between that. So women don't have a refractory period, which is awesome, which is good, which again allows women to have more of a chance for those multiple orgasms to actually happen. So in comes Rosemary Basson in the 2001 that said, I can't buy the linear model for Masters and Johnson when it comes to the female sexual response. And so she talked to a lot of women, did a lot of research on this, and said, it's not necessarily that women have to have spontaneous desire right off the bat. But a lot of times it's the emotional connectivity that you have with your partner. It could be that you start to feel aroused and then you become, have that desire. Oftentimes I will tell my patient that if you're, at the kitchen counter and you're chopping up dinner and getting it ready and your partner comes up behind you and they kiss your neck and you feel their touch and their embrace around you, that you might start to feel some genital swelling in that area. And then the desire comes. So it's not always just, again, this very linear model, that a lot of it is overlapped and very circular within that response cycle. So although a lot of women can be very linear too, it all depends on your situation and individually what is actually going on. Okay. Alrighty, so now comes the impact with women's sex and then breast cancer. So we see a lot with the types of surgeries that happen. Depends on the type of breast cancer that you have. It depends on your risk factors and what's going on, whether you decide to have a mastectomy, bilateral mastectomy, a lumpectomy, and then combination treatment as well. When we think of women, what do we think of? We think of the femininity, we think of the curves, we think of the body and the breast and erect nipples. We're thinking about all of those types of things with the body image, right? Oftentimes, again, when I see my trans female patients, one of the first things that they say to me when they walk in and we start hormone therapy, they want breasts. Because breasts in our culture, in our society, the message is that's female, that's woman. So when we start talking about taking away someone's womanness, it really impacts their identity and who they are and how they feel. We don't see this as much when women go in to have a hysterectomy or to have their ovaries removed. It's not visual, right? We're not seeing it as much. Women aren't associating necessarily with that part of their body as identifying of who they actually are. They can't touch their uterus. They can't touch their ovaries. They can't really feel that. So for them, it doesn't feel as something that is theirs. But when you start talking about breasts, that's a huge impact on how women actually feel about themselves. So if you have a mastectomy or a lumpectomy, what happens, even if you decide to have reconstruction, there's a lot of loss of sensitivity to that area. Even if you decide to have a nipple sparing surgery, you may still have loss of sensation to those areolas and the nipples. A lot of women love to have their breasts touched, love to have their nipples rubbed, tugged, any type of thing like that. It's very, very stimulating sexually for them, and actually can help a lot of women reach orgasm. We know that there is a smaller percentage of women out there that just through nipple stimulation alone can reach orgasm. So again, it has all that to do with that oxytocin and the dopamine that's going on in your brain to then send those firings off for an orgasm to actually happen. Then what happens is we start to worry about how our partners are going to think about this and what our partners say about our body image. Again, we have to remember that it's not always about the partner, that a lot of it has to do with how you feel in your body. And so I often will say, bring your partner in, let's have these conversations. So you are, again, going in for your oncology appointment, you've got your diagnosis. Again, you're just trying to live and process the fact that you have cancer at this point. Sexual health and intimacy is not always on the forefront of your brain of thinking about, well, what's going on? What am I going to do? You want to survive. And we get that. I love to see women at the time of diagnosis because we get to talk about how they're functioning sexually now and how that's going to change over time. I am not saying that providers are not doing a good job about talking or bringing up the conversation, but they're not doing a good job. They're not talking and not having those conversations. So we need to do a better job. We're so focused on being able to take care of that cancer and fix it, right? And for the longest time, just like when I did my research on female sexual health, there was nothing out there for women. So when we start thinking about, well, we don't want to ask the questions because we don't have the answer. We don't know what it is. And so, but now we have lots of treatments and options. And again, like I said, we will talk about those here shortly. The other thing too, so bring your partners. I mean, that was what I was trying to get across. Is bring your partners in with you. They may not think that this is part of their life and what's going on, but it is. It's going to affect them one way or another, and they're going to need somebody to talk to. They need information also. They need to know what's going on with your body. When I talk to partners, they often will say to me, I didn't think this was going to happen. And I thought maybe this would be happening for a short amount of time, but that things were going to get better and they would get back to normal. I hate the word normal. Nothing is ever normal. It always is something that I talk to people about of being common. There's a lot of things that are common, but it doesn't necessarily mean that they are normal. So, again, setting realistic expectations and having that conversation about what's going to happen is really important with that partner in the room also. We often will see lower libidos with women that have surgical removal of their breast or even a lumpectomy. A lot of that doesn't necessarily mean a hormonal influence of that. So we know that testosterone has a big impact on how we feel, both energy, lean muscle mass, how we sleep, but it also has a lot to do with our libidos. For this one though, a lot of that body image comes into playing, I don't feel sexy, I don't feel like myself. Why would I want to have any desire to be with my partner if I don't feel like me? So a lot of this is mental, psychological impact of lowering that libido. A lot of women go through depression and they're on depressive medications, and those also can inhibit the libido as well. Then we have some combination treatment with radiation. Again, we have scarring and body image concerns. You can have a lot of numbness and decreased sensitivity, a lot of loss of mobility. so if you really liked to have your arms up over your head during sexual activity, and now you have this scar that's and scarring of your tissue, and you can't do that, working with a physical therapist to really open that area up. We don't have these conversations. We don't think about these certain things. So again, just thinking outside of the box is going to be really important. And a lot of times we have fatigue. You may feel just really sick and have flu-like symptoms, and you don't feel like being sexy. You don't feel like being intimate with your partner. But there's a lot of things that you can do to still be intimate and hold that connection with your partner despite feeling kind of crummy. A lot of times women will decide to go ahead and have a prophylactic hysterectomy and then removal of their ovaries. So BSO is a bilateral salpingo-oophorectomy, meaning that's a big word, meaning that we remove the fallopian tubes and the ovaries as well. There is a lot of research and studies that show that there's a correlation between ovarian cancer, uterine cancer, cervical cancers, and breast cancer. So a lot of women will decide to go ahead, depending again on their breast cancer diagnosis, for this type of surgery. This oftentimes leads to a shortened vaginal canal. So if your partner has a longer penis, or if you have a female partner or just any kind of partner that has hands, then you may have difficulty with best digital penetration, fisting. I have lots of women that participate in many different types of activities, and that could greatly impact that. You do get some lubrication from those cervical glands, and so we notice that there can be lack of vaginal lubrication and moisture in that area, and then loss of genital sensation too. There's a lot of blood flow that comes from that uterine artery to the genitals that supplies the pudendal artery, which supplies the vulva and the genitals. And so I have seen with some of my patients that they've lost some of that blood flow and the nerve sensitivity in that area after this type of surgery. So what about chemotherapy? Definitely if women are young enough, and we are seeing a lot more breast cancers being diagnosed in younger women, especially in their 30s and 40s, that this is causing a premature menopause. They're getting hot flashes, night sweats, mood changes, acne. Again, feeling like they're losing their femininity, loss of hair. If we're still thinking about babies, right? That what is our fertility and what are our options? What do we need to do to retain that? This also causes a lot of inhibition to the estrogen receptors and the testosterone receptors in the vaginal canal, leading to thinning of the vaginal tissues, loss of moisture, loss of lubrication, leading to dryness, and again, low libido because it's affecting those ovaries. Ovaries help to give women both testosterone and estrogen. What we don't hear a lot of is that women have 10 times more testosterone in their body than they do estrogen. You need testosterone. It's the precursor to estrogen in order to have that hormone in your body. So when we start having chemotherapy and it's a systemic treatment, it really impacts those ovaries, and that's where we get our testosterone. So that's going to really limit too. Then you start messing with the microbiome. The vagina loves to be acidic, anywhere between 3.5 and 4.5 pH. When you disrupt that microbiome and those normal bacteria that are in the vagina to help keep it acidic, and those die off and that pH starts to rise, it leads you to a lot more vaginal infections like yeast or bacterial vaginosis. So if you have an infection in the vagina and you're dry, now you're irritated, you don't want to stick anything in there. That's not what's going to be helpful. The other thing too is because of chemotherapy, you're lowering your immune system, and that can lead to flares of any type of genital herpes or genital warts. So we have to be thinking about that too if you are partnered, and making sure that we are safely talking to you about safe sex practices if that's happening. Because chemotherapy is filtered through the kidneys and gets into the urinary tract and can cause a lot of bladder irritation. A lot of times women think that they have bladder infections, and that's not the case at all. It's just irritation to the lining of the bladder causing urgency and frequency of that patient. Now, granted, I have seen some chemotherapies and even hormone therapies like aromatase inhibitors that can cause urinary tract infections in women. So again, this isn't an uncommon thing. Although it says Fosnight Center for Sexual Health on there, I still have carried a lot of my urology background with me and still treat a lot of recurrent urinary tract infections. The other things to think about with your bladder and anything in the pelvis is that there are estrogen and testosterone receptors in the lining of the bladder, in the urethra, in the pelvic floor muscles, in the fascial tissues, in the ligaments, in the tendons, in the muscles of your pelvis. So when you deplete all of that, that's going to lead to a lot of irritation also. And then we start talking about hormone therapy, right? We get to the point now where we are preventing recurrence from happening. We're being placed on tamoxifen or an aromatase inhibitor like anastrozole or letrozole. And what that's doing is really then lowering even farther our hormones in our patients or in your body. So with tamoxifen, it's decreasing the cell sensitivity to that estrogen. And then with anastrozole, what it does is it actually decreases that testosterone conversion over to estrogen. We really see a lot more worsening of vaginal dryness in those aromatase inhibitors. So again, something to just think about. Okay, so now we've talked about all of that. This leads us to the big thing, right? The sexual health concern piece of it. We know up to 85% of women that are going through a breast cancer treatment or afterwards have a sexual health concern. And this can last years after your diagnosis and after your treatment. So if this was not necessarily addressed at the beginning or even shortly afterwards, this is something that you're thinking that you have to live with. And again, that guilt factor comes into play of, I'm alive, I should be happy. You can't always think about what you should be happy about or guilty about. If you're feeling something, you're feeling something, and that should be validated. And know that you're not the only one that's thinking that you want your old life back, that you want to be normal again. Why is this happening to me? One of the biggest things that I talk to my patients about too is grief. We have to grieve what's going on and grieve our previous selves and how we were functioning and focus on the hope that we have for something better. Right? So just because we're no longer having sex maybe the way that we had it before, there are lots of other ways to have sex, and there are lots of other ways to have an orgasm, and there are lots of other ways to be connected with your partner. And those are the fun things that we get to explore during your process and your journey through this. So here are the big things that I see on the sexual health concerns. The two big ones are there at the top. So low libido and vaginal dryness. And that vaginal dryness then leads to that pain with sexual activity. If the vagina is dry and it's lost a lot of the elasticity, it doesn't have the capability to accommodate anything to go into it anymore. And then when we have too much friction, it's going to cause a lot of tearing, bleeding. We even have what we call these micro tears that sometimes you don't even see, which lead to pain and infections also. The other big thing I see is difficulty reaching orgasm, but it's really important for me to know, was this something that you had before treatment, or is this something new? And again, another reason why I like to see patients before we start their treatments, it really helps me to put in perspective of how are you functioning beforehand, and what are the things that we need to talk about and move forward with first. Again, if there are treatment options done to the breasts, then loss of nipple sensation is going to happen. And like we said, we talked about body image and then how the partner is functioning as well. So let's jump right in. The other thing to think about too, and this is something that I talk to my patients, and we just talked about pain, right? Pain is very interesting, especially when it comes to sexual pain. If you can look at our pain cycle here, there at the top when it says the body anticipates pain, we have an autonomic reflex response. Our body tightens up. It's a protective mechanism. It doesn't want to have that pain again. So why would we want to go through that? So then that tightness, and this usually happens in your pelvic floor, and those pelvic floor muscles in your pelvis are that wrap around the urethra, the vagina, and the rectum. So that tightness then causes any type of sexual penetration in that area to be painful. That pain then reinforces that reflex response that you had. And then your body braces for even more. So it tightens up even more and it braces even more for that. And then you avoid the intimacy. So I tell people all the time, why would your body want to go through something painful and it desire that? Now, BDSM is a whole nother conversation, and pain versus pleasure, we could talk about that too. But for this purposes, your body is a protective mechanism. It's protecting itself against any pain. So it won't signal off, sex, sex, sex. That's what I want to have. It's what I want to do. No, that causes that thought process causes pain. So our bodies are super protective in that regard. So it's going to lower that libido. It's going to take away that testosterone. It's going to block those receptors. We don't want sex. It hurts. We don't want to go there. We don't want to do it. Then you start avoiding intimacy. And that's when then things start happening with your partner, with yourself, and thinking about all of those negative things that are going on. So again, this is that pain cycle. When I tell people when they have low libido, again, typically everything's overlapped when I see a patient and they come in. Usually, again, low libido and pain, which happening from the vaginal dryness, is normally what we see. So in that regard, what's happening is that they think, I need something for my libido. And that's not at all. I could throw all of the testosterone in the world at you. It's not going to help because that pain is there. So we have to refocus on is the pain that you're feeling so that we can then focus then on the libido. And it's amazing once we get the pain under control of how much your libido and that desire and that spark actually comes back again. So what do we do, right? So you come to see me, Aleece, let's talk about those things. Give me some answers. So I am very excited to say that we have options now. We have safe options. One of the biggest things with my patients, whenever we start treatment options, hormone therapy, medications, anything like that, my utmost important piece, the first thing that we do is safety. I really want to make sure that my patients are safe and what we're doing is going to be beneficial and not harmful whatsoever. So when we start talking about the libido side of it, again, is this something that's psychological? Is this physiological, how you're functioning, or is this both? I need to figure out what's going on. Again, I could give you all of the medications in the world, but if that pain is still there, or if this is a relationship concern, now you're having fight and conflict with your partner, I can't increase that libido. I can't change that situation for you. So we have to really piece it out, and I get to do that by asking a lot more questions on my intake, and then during just our first time appointments and the time that we meet together. There are some hormone replacement options. When we talk about hormones and breast cancer, we still have this protective mechanism in our brain that hormones are bad. It all depends on what hormones that we're actually talking about. Estrogen, probably not a good idea. Most of the time we're seeing that estrogen actually increases the risk. And this is definitely oral out. Oral therapy is not going to happen. I do a lot of hormone replacement with pellet therapy. So pellet therapy, they look like a grain of rice. It all depends on the type of compounding pharmacy or the dosage that you're getting. And we place those underneath the skin. Those can be really helpful. They provide kind of consistent hormones, but you can't take them out. So here's the thing, again, safety with my breast cancer patients. So those are out to you. We don't do oral, we don't do pellet therapy. I tend to do topical hormone therapy. And I have talked to lots of oncologists, and we have lots of clinical research out there that shows that using DHEA or even topical testosterone can be very beneficial. Now you're going to say, Aleece, DHEA can get transferred over to estrogen. Yeah, it sure can. But we know DHEA is also the precursor to testosterone. And both of those things can really help women with feeling balanced, removing the fog, having a better mood, increasing their libido. And I start low. So when I have women come in who are perimenopausal or menopausal, and they're looking for options for hormone therapy, we kind of have a normal range, okay? It's where we start women out on those. For my breast cancer patients, I do a half to a quarter of that normal dose we normally start with. So we start really low and we titrate up. Now, testosterone, DHEA and testosterone, I have to say, are not FDA approved. These are off-label uses. DHEA is going to be in a form of a compounded. We have no actual prescription that I can write to you that is coming from like your normal retail pharmacies like Walgreens or Walmart. This has to be a compounded formulation. There are testosterone gels out there for men, but those are going to be at a much higher dose. So I tend to compound the testosterone that women need, be able to give them 1/10 of the dose of what actually men do. So for my testosterone, 5 milligrams a day would be, again, that normal dosage for a woman coming in with no risk factors. And for my breast cancer patients, we start at 1.25, we start at 2.5, we start low. I'm also doing labs beforehand too, so I can see where you're at. If you are super duper low, then I need to start super duper low for you. And so that we can help your body to accommodate for these new changes in your hormone levels. So that's those are the types of things. Again, everybody is different. If you are looking for something that is not a hormonal based type of medication, we have two options. So we have Aleece, which is an on-demand injection that you can actually give yourself. It comes in an auto injector. You do this in giving it on either side of your belly button in your lower abdomen. And this is going to be more of an on-demand type of medication. So Aleece is bremelanotide, so it's a melanocortin. Melanocortins are actually a type of receptor and hormone in your brain that stimulates desire to actually happen. So you can inject yourself 45 minutes to an hour before intercourse or intimacy is going to happen. And that's going to stimulate that spark, okay, that spark in your brain to go, you look across the room. Yeah, they're looking kind of sexy. They're looking kind of hot. Okay, yeah, maybe we can do something. The other cool thing about Aleece that hasn't actually been studied or it's not an indication, but we're looking at it now at this point is some genital swelling that can happen and some arousal. So I had a patient who has done Aleece and she called me up 8 hours after she had injected it and she said, Aleece, my genitals are swelling. I feel aroused. Like, what's happening? She enjoyed it and she liked it, but she was at work. It was not the best place for us. So one of the things that can happen too with Aleece, again, not an indication yet, is that it can also help with the arousal piece also. But then we have Addyi. Addyi came out in 2016 and was supposed to be the little pink pill, although its mechanism of action is nowhere near the blue pill like Viagra. So for Addyi is going to help to stimulate, again, the thought processes in your prefrontal cortex to give you more thoughts. Addyi is something that you take on a daily basis. This is for somebody who doesn't necessarily want to be as planned with their sexual encounters. They want something that they're going to be thinking about sex or having some thoughts or some feelings more like on a daily basis. And so this really can be very helpful for those patients to actually do that, again, that don't necessarily want a hormonal type of therapy. And then obviously, if there is a discord within the relationship, partner concerns, conflicts, there is always the potential to refer to a sex therapist or a sex counselor as well. And oftentimes, it's not just the patient that's having concerns, it's the partner too. The partner doesn't want to hurt their loved one. They don't want to pressure them for any reason. So it's having those conversations with your partner. That's why I like for them to be there at their appointments too, to see what's going on and how we can be helpful. When we start talking about vaginal dryness and pelvic pain, this question comes up a lot of what can we do? I have a lot of vaginal dryness. I have a lot of pelvic pain associated with this. So the big thing is, again, there's a lot of non-hormonal things that you can do. So moisturizers are great. There's a lot that you can get over the counter. You don't have to have a prescription for. There is one that has hyaluronic acid in it, which is really good. You need hyaluronic acid to retain the moisture in the vagina. There are ones that help to restore the pH, which can be really also as well. Moisturizers are going to be like the lotion that you put on your skin every day, just to keep it moist, to keep it hydrated. So that's something that you can do all the time. Lubricants are more for during intimate moments, sexual intercourse, sexual play, anything like that. The thing about moisturizers and lubricants is you want to avoid any type of glycerin, parabens, or fragrances. This is not the time to get this his and her cooling, tingling, and none of that. It's just going to light your vaginas on fire, and it's not going to be any kind of sexy whatsoever. So those are the things that you're going to have to think about. There are differences between a silicone lubricant and a water-based lubricant. Think about the vagina as a desert at this point. And if you put water on there, what is it going to do? Suck it right up. You're going to have to keep reapplying and reapplying. So typically I recommend a silicone-based lubricant that can be really helpful to help keep that lubrication in there so that you decrease the friction and you actually increase sexual satisfaction and stimulation during that time also. So silicone-based lubricants are great. The other thing to think about is coconut oil. I get that question all the time. So coconut oil is great. There is, again, still kind of some controversial studies out there for people that are more susceptible to yeast infections, that it actually might cause more of those. But again, talk to your provider and just see, is this an option for me? Can we do this? The coconut oil is great. If you get the unrefined coconut oil, you may even smell like a pina colada. So it has more of a coconut scent to it also, which is great. So you can do that at the same time also. But what if that's not enough? Then there's other things that you can do that are more hormonally based options. We've had recent research that has come out, more clinical studies that have shown that using a local hormone therapy does not increase your risk of breast cancer. This is fantastic. We know that when you have localized hormone therapy, it stays there because that's where it needs to go. Very little, if any, actually gets absorbed systemically. And when these studies came out, they actually looked at serum blood levels. So again, looking at your systemic blood levels of estrogen. So for like DHEA, so progesterone or Intrarosa is the brand name for that. These are vaginal suppositories. Remember, DHEA is a precursor to estrogen and testosterone. And so what this does is it stimulates the estrogen and testosterone receptors in the vagina and the vulva, which is great. The opening to the vagina actually has testosterone receptors. The top part of your vaginal wall has testosterone receptors, and the clitoris does. So applying estrogen alone does not always get the job done. So when they did studies looking at estrogen systemic levels, they did not increase higher than the placebo ones did. So we have enough data, but again, we still don't have as much research as we would like, but we do have some more of these safety data that help us to at least give our patients a lot more options, especially when conservative methods like moisturized lubricants and just even purely stretching the vaginal tissues just aren't enough. You can also do a non-FDA formulation of a compounded testosterone vaginal cream. Also, again, testosterone is a precursor to estrogen, so it can stimulate both of those receptors at that area. And then if you have pain, right? So remember that pain cycle that we just talked about? What that does is your muscles actually tighten up from that as well. And so getting a pelvic physical therapist can be a great way to help to relax and downregulate those muscles. And it's more of a neuromuscular type of connection. It's those nerve signals that are sent to your brain that this doesn't feel good, this is not safe. So with a pelvic physical therapist, they can help train you to let your muscles relax and say this is something safe and that this is something that we can do. The other thing too is we can talk about trigger point releases, and those can be really good options for you as well. Okay, how about difficulty reaching orgasm? A lot of that has to do with increasing the blood flow and the nerve sensitivity to the genitals. And we can do this with Viagra and Cialis. So we have some studies that show that women can take these types of medications, but we just don't have enough of them. So when I do an assessment with my patients, and we're talking about difficulty reaching orgasm or an inhibited female orgasm, that the fireworks aren't as spectacular as they once were, I will oftentimes do a clitoral Doppler ultrasound. I'm looking at the clitoral blood flow in a resting state. So there's certain levels at what it should be. And I do find that in women that have had breast cancer treatments, or have been on other types of hormonal therapy, that blood flow is really gone, that we've lost a lot of that. That decreases the tissue compliance. It's not as robust as it once was. We've lost a lot of nerve sensitivity to it too. So by taking oral Viagra on a lower dose of what we would actually do for men, or oral Cialis, you can really help to potentiate the blood flow, especially on a daily basis. You can also do some topical compounded creams. So like I said before, like DHEA or testosterone, we can add in these types of medications to help stimulate blood flow as well. You can also add something fun, oxytocin, either through orally, where it's a little, they call it a troche, and it's dissolved in your cheek, or a nasal spray. That can be really beneficial. Oxytocin is the hormone, again, that's released during orgasm. So it can help give you back your orgasm and or make that orgasm more intense for you. Pelvic physical therapy, again, it's really good here too. Those tight muscles actually limit blood flow from getting to your genitals. So by opening up those muscles and allowing that blood flow to, again, rush to the vagina and the vulva, it can really make a big difference in the sensation that you're feeling. What about, again, loss of sensation? So again, this spills over to this as well. So again, using some vasodilation can be very helpful. Using oxytocin to the area, using some sort of neuropathic type of medication like gabapentin, amitriptyline. Those medications can be very helpful too, even if you actually have increased sensation. So there is another type of sexual diagnosis called PGAD, which is persistent genital arousal disorder. We're looking at some other types of names, medical names for it as we're learning more about it. But this could be that you're having too much sensation. And a lot of people are like, yeah, I want more sensation. But if you're having it all the time, it gets really old really fast and becomes very uncomfortable. So if that's the case, we can talk about adding some of those neuropathic medications as well. And then using an external vibratory device, a vibrator, right? That increases blood flow, that increases nerve sensitivity, that can be really helpful also in helping bring back that blood flow and bringing back that sensation to you. And then again, physical therapy as well. When we talk about loss of sensation, this isn't just to the genitals. This can be to the chest as well. You can totally use a vibrator on your chest to help stimulate that blood flow. You can use it to the nipples. You can use it to the breast tissue, to the chest wall. Any of those types of things can be really helpful also. Okay, so this is where the sex counseling piece actually comes into it. So when I'm doing my intake and I'm asking those questions, I have my basic sexual history. You know, how do you identify yourself? What's your orientation? What are the types of sexual activities that you participate in? I get to take this up a notch when we start talking about sex counseling and how is the relationship? How do you communicate with your partner? Does your partner know if you're having any concerns? Does your partner even know that you're here today? Are you having the type of sex that you want? Let's start having those conversations about what you're looking for and why you're actually here. So again, this also means that I get to ask about your history. What were the messages that you received growing up? What was the relationships like in your family? So again, we get to have those conversations more in depth to figure out what's going on and where is this coming from, right? So again, really looking at yourself also. One of the biggest things that I make sure when we start talking about sexual activity, looking at improving sexual function is, why are you doing this? Why are you doing this? If the conversation starts to take a turn and, well, my partner really wants me to be here. My partner wants to have sex more. My partner. If we start talking a lot about your partner and that your partner wants you to be here, the goal is not going to be directed at you. You're going to have resentment. You're going to feel frustrated. There's going to be more conflict that's going to happen when things don't get better like you thought that they were going to. And so the biggest thing is you need to be here for you. This is something that you need to do for yourself and yourself alone. And that's where it goes into a lot of these self-affirmations. We oftentimes tell ourselves we're fat, we're ugly, we're not pretty enough, we're frumpy, I don't feel good today. So when we start talking that way to ourselves, I really want you all to start thinking about, would I say this to my best friend? Would I say this to my mom? And if you are going, no way, I would never say this to somebody else, then why are you saying it to yourself? What are the messages that you are telling yourself, and why would you even have that conversation with yourself? When you start rephrasing and becoming more positive, that really makes a difference in your brain, and being consistent with those also. So I will oftentimes have my patients write down, I want you to write down 6 things that you love about yourself. What do you admire about yourself? It doesn't have to be that you're pretty or that you love your smile. It can be that you're strong, that you're beautiful, that you are independent, that you are resilient, that you are a caregiver, that you love butterflies. It could be anything like that, something that you admire about yourself. And then what you're going to do is you're going to take those statements that you've written about yourself, and you're going to put them on sticky notes, and you're going to put them everywhere that you're going to see it. You're going to put it on your bathroom mirror. You're going to put it inside the refrigerator. You're going to put it inside your lunchbox. You're going to put it on the visor of your car. You're going to put it in all of these different places so that you see it all the time. When we do self-affirmations and we do them consistently on a regular basis, they really actually change the way that you think. And so that's going to be a big tip that I talk to a lot of my patients about. And that really helps them then to refocus their goals. Because that's going to be really important of, again, why are you here? What are you wanting to do? And then setting realistic expectations as well. When we start throwing the word normal out, things start to move in a more positive direction for those goals. The other thing is mindfulness. We get caught up in the daily routines of our busy lives, especially for those patients that are diagnosed at an earlier age, where they've got young children, they're in the midst of their career, and trying to figure out, what are we doing? Why am I here? What's going on? And there's so much going on that it really blurs your brain and blurs your thoughts. So mindfulness is taking 5 minutes to really focus on breath, to focus on being present in the moment, and having those conversations with yourself. Again, this can be a time where you sit in a quiet room. You could have some music on if you wanted to, but with no words. I tell people, don't do it with words, because then you start singing it in your head and you start thinking about it. But if you have those affirmations, I am beautiful, I am strong, I am resilient, I am tenacious, and you start thinking about it, things start to get calmer, you become more confident. And the other thing that I tell people to do too is there's going to be days that you don't feel good. So do things that you can change, that you have control over. You can paint your fingernails, paint them whatever color you want to. If it wants to be neon green, it makes you happy, do it. As long as it's within your job limitations and whatever else. If you want to wear bright red lipstick or bright pink lipstick on a daily basis, do it. If it makes you feel good, do it. Body movement is so important too. The more your body moves, the more you feel better actually in your body. Body movement actually helps to increase endorphins and does release dopamine. Also, dopamine is that good feeling hormone in your body. We talk about scheduling intimacy also. Again, we get really bogged down. A lot of people fight me on this one about scheduling intimacy. Scheduling intimacy, not scheduling sex, right? So we really thinking about, and as you can see here, right? What is sex counseling? Sex is not on this list, okay? So, scheduling that intimacy means scheduling a date night, scheduling time that it's just you and your partner. Shoot, you can schedule a date night for yourself. That's totally fine to do too. If you need time to soak in a bathtub, to read your book, to have time with your external vibratory device, do it. Those are the types of things that you need to get scheduled. If you don't put it on your to-do list, on your calendar, it's not ever going to get done. Kissing and touching exercises. This is really important because kissing and touching is often seen for women as that first step in the process of sex happening. So when I talk about kissing and touching exercises, that's it. It does not move any forward with that. Kissing is going to be really important because it's those nerve endings in your lips that actually send signals to your brain. But here's the kicker. You need to have kissing for 60 seconds at least. So a 1 to 2 minute kiss. I want you to think right now, when was the last time you had a really good makeout session with a partner, right? If you're in a longer term relationship, you have gotten kind of complacent in your relationship that's not necessarily happening anymore. So we talk about kissing. Kissing is really good to stimulate, again, those good feeling hormones and chemicals in your body, make you want and desire. This is all foreplay too. This is all really good things and build up. I tell people all the time, foreplay happens at the end of that previous sexual encounter. It all builds up to, again, that next sexual encounter and sexual play that you're having. We also know that research shows us that the more that you are touched throughout the day, again, the more those endorphins are being released in your body and those good feeling chemicals. Sensate Focus is good. It's a series of exercises of relearning touch with your partner. So that can be really important, especially with body image and finding out where it's safe for your partner to touch. We do that a lot with body mapping also. You can have a Q&A session. So John Gottman, as a researcher who has come up with a card deck app. So you can put it on your phone, okay? So you can download it, and it's just a series of questions that you and your partner can just have a conversation. It really helps to put into play those communication skills so that you can talk to your partner about everything and anything. The hand over hand exercise is really good too, again, to learn touch. And sometimes we can combine this again with that Sensate Focus. So it's you can have your hand on your body and then your partner's hand is over top, and you guide them and you lead them. Whenever you feel that it's safe and you want them to do that, you switch. And again, this could be weeks later. It doesn't have to be within that same setting. So you can switch and then guide your partner again with their hand on the bottom. So it helps them to relearn touch and what actually feels good in your body. The use of toys, right? You can see on my shelf back here, we have lots of different toys that you can use. Bringing in a vibrator, bringing in nipple clamps, bringing in bondage types of devices. Again, this is something for you to start looking outside the box and figuring out what's going on. And then I have a whole bunch of books and websites, and then thinking about referrals. So again, finding out who in your area you could go talk to. So NAMS, which is the North American Menopause Society, is great. They have, you can locate your professional on there. ISWISH is great. It's the International Society for the Study of Women's Sexual Health. You can locate a provider also. Again, I'm part of all of these. And then ASECT. So it's the Sexuality Educators, Counselors, and Therapists. If you wanted to locate a pelvic PT, here's those websites. The books that I think work the best to help guide you are these 3 books. These work really well in any type of sexual relationship. And I really like this Intimacy After Breast Cancer. It has a series of exercises in there that you can do for yourself as well as with a partner. So I want to leave you all with the fact that this is complicated. This is overlapping. There are a lot of pieces to the puzzle. It's not one thing that is causing you to have a sexual health concern. It's all of this together. And then we have, again, that biopsychosocial model of now we have influences. Our body's not functioning like it's supposed to. We have all these messages that we've grown up with. We're blocking ourselves. We're having a partner conflict. We're not communicating like we did before. We're starting to shy away and avoid intimacy. So it's all of these things together. The thing that I like most about sexual health is the fact that it's all individual. Everybody has their own erotic templates. They have their own sexual scripts. They have their own sexual selves. And for me to be able to help open up a patient's viewpoint and to help them discover that is one of the most honorable and grateful things that I have ever experienced. And I am just grateful and blessed every single day that I get to do the work that I'm doing. So I know we talked a lot about this topic, and I could go on for hours and hours. But what I'm going to go ahead and do is sharing my screen and just to see if there are any questions out there. Any questions from anybody? I know one of the questions that somebody had sent to me prior to, they weren't going to be able to actually make the webinar. And again, this is being recorded, so you'll be able to check back to our website and see this again. But one of the things that the conversation was localized hormone therapy. And so I really want to make sure that people understand that being able to use localized hormone therapy does not increase your risk of breast cancer. And that the studies that we do have out there right now, it's very promising in the fact that it doesn't show any increase of recurrence with breast cancer as well. So there's definitely options And sexual health, again, is a really important topic for conversation and definitely a big passion of mine. If you can't already tell that through this webinar. So, well, wonderful. I don't see any questions at this time. And I know sometimes it can be intimidating being on a webinar, but please always feel free to reach out to me. I'm more than happy to answer any questions that you have. You can always reach me at Aleece, which is ALEECE at fosnightcenter.com. And you can always visit our website too, which is fosnightcenter.com. There's a place for you to send questions, and you can get more information about other things that we do here at the Fosnight Center. Again, I see everybody and anybody for sexual health concerns. So, all right, well, we have been on here for an hour. I want to respect everybody's time. Thank you so much for joining us this evening for me to talk about sexuality and breast cancer during Breast Cancer Awareness Month. Be on the lookout. We will have more webinars like this. So we'll have another one coming up in December. And then we always have fun during February, which is Love Month. So be on the lookout for that. We'll have some more webinars. We're going to have a panel of sexual health experts so that you can come and ask us anything. Nothing is off limits on that one. And then we'll have a virtual sex trivia as well. So be on the lookout, stay tuned. Like us on Facebook, join us and follow us on Instagram, and I look forward to seeing you all if you are patients. I'd be more than happy to help you again on your journey. And please know if you are a provider on this, I'm always available for questions, first of all, and then please know that your patients will be well taken care of if you refer them out to us here. All right, thanks so much, guys. Have a good evening.